Hello everyone and welcome to our channel that is AACCM, that stands for Anesthesia and Critical Care Medicine. Myself Dr. Sahil Gupta, and in today's lecture I'll be dealing with the basics of ABG analysis. So let's start to the topic. So ABGs, why is it useful in today's scenarios? Because it gives us the three basic concepts, that is, first is your alveolar ventilation, second is your oxygenation, and third is your acid base balance. So in from one ABG we can have the ventilation perspective, the oxygenation perspective, as well as the acid base balance. And not only that, there is another advantage that we can have the electrolytes, that is the sodium, potassium, calcium, and lactates. So all these are very important in a setting of critical care medicine or anesthesia or in any field. So let's start with the alveolar ventilation. As we all know that from the alveolar ventilation, what we means that the CO2 levels corresponds to the alveolar ventilation. If the ventilation is good, then the CO2 will not rise. Okay, so from alveolar ventilation, we can have a scenario and we can deduce the levels of PCO2. PCO2 can be diagnosed from a simple equation, that is CO2 by VA, where CO2 stands for the arterial CO2 tension and the VA stands for the ventilation from the alveolar part. Coming to the second point, that is oxygenation. A normal PO2 levels at room air, that is with FiO2 of 21%, is around 80 to 100 for a normal human adult. Now again, what I mean by adult is because with age this PO2 level varies. Okay, so in-depth analysis will deal it in a later class, but you have to remember that FiO2 of 21% at room air, we the normal PO2 levels is 80 to 100. Okay, and again the normal PCO2 levels should be 35 to 45. The third is the pH. Okay, that is the acid base balance. I hope I'm clear till now. Okay, so coming forward, now what is the normal pH, what is the normal PO2 level, what is the normal POCO2 level? Okay, but before going to this point, we have to remember one thing, that whenever someone shows us an ABG, the ventilatory settings should be there. Without the ventilatory settings, without the FiO2 levels at which the ABG has been taken, the ABG is of no use. Okay, so you have to remember whether the patient is on mechanical ventilation, whether the patient is on NIV support, whether the patient is on oxygen support through nasal prongs or through the oxygen mask, or is it at the room air. Okay, so you have to remember this basic point about ABG, that ventilatory settings or the FiO2 has to be established before deducing the normal pH, PO2, PCO2, or any values deducted from the ABGs. Now, again, from the ABGs, we can also deduce, that is bicarbonates, a base excess, and as I told you, electrolytes as well as lactates. In some of the ABG machines, we can also have the values of HB. Okay. So coming again to what are the normal values of an ABG, again we have to see whether it's an ABG or a VBG. Okay, let me just erase it here. And what are the normal values of all these things? So the normal value of an arterial ABG, that is ABG is an arterial thing, VBG is a venous thing. Okay, so the pH of a normal thing should be 7.36 to 7.44. Here it should be 7.34 to 7.42. The PO2 levels should be 80 to 100. Here I'm talking about room air, okay? 80 to 100. Here it is 37 to 42. The PCO2 levels should be 35 to 45 in a normal ABG. Obviously, in a venous sample, the PCO2 level should rise. It should be 42 to 50. The bicarbonate levels in an arterial thing should be 22 to 26, and the base excess should be plus minus 2, and the saturation should be 94 to 100%. Again, the saturation should drop in a VBG. I hope I'm clear till now. Okay, so what do I mean by bicarbonates? There are two types of bicarbonates which can be deduced through an ABG sample. The one is the actual, one is the standard. Okay, so what is the actual bicarbonate level that is calculated from the blood sample? What is the standard or the corrected bicarbonate levels is the value of the bicarbonate had the sample been corrected to 40 millimeters of mercury, sorry, 40 millimeters of mercury, and secondly at room temperature. The standard bicarbonate level gives us the metabolic component of an acid base balance. Okay, now coming again, what is base excess? As we all know that the normal pH is around 7.4. Okay, so the base deficit or the base excess stands for the amount of alkali or acid that must be added to the solution to bring back the altered pH to normal. Okay, so let's say if the pH is around 7.4, we have to add acid to this to bring back the pH to 7.4, and vice versa. If the pH is around 7.3 or 7.2, we have to add alkali to that to bring back the pH to normal. Okay, so this is the base excess or base deficit. Okay, now coming to how to interpret an ABG. The first rule of interpreting an ABG is by saying the pH. Okay, there are various points in analyzing the ABG. The first is the look at the pH of an ABG. If the pH is, as we all know, the normal pH is around 7.34 to 7.44. For easy remembering, we can take it as 7.35 to 7.45. Okay, so anything, if the pH is less than 7.35, it's called acidic or acidosis. If the pH is more than 7.45, it is called alkalosis. I hope I'm clear till now. So if the pH is less, it's more acidic. So it is called acidosis. If the pH is more, it is alkalotic and it is called alkalosis. Again, if we divide it into further points, the acidosis can be metabolic or respiratory, as well as the alkalosis can be metabolic as well as respiratory. Okay, so again, the acidosis in respiration can be an acute event or a chronic event, as well as alkalotic can be an acute event or a chronic event. So, if we see clearly, now we have around 6 primary defects of acid-base abnormalities. Okay, there are other defects also where we have mixed acid-base disorders that will be dealt in a later class. So today we will be dealing about the basic 6 abnormalities in the acid-base problems. So coming again, to remember it easily, the metabolic component is by bicarbonate change and the respiratory component is by the change in CO2 levels, that is PCO2 levels. Okay, so any delta change in the bicarbonate levels is the metabolic component and any change in the PCO2 levels is the respiratory component. So coming back to the previous thing, in the pH of less than 7.35, if it's acidosis, okay, and if it's the bicarbonate that is decreasing, it is called metabolic acidosis. Okay, in the alkalosis picture, if the bicarbonate is increasing, it's called metabolic alkalosis. Okay, so in the respiratory component, both in acute and chronic, if the CO2 levels are rising, it's called respiratory acidosis, and in both of these, if the CO2 levels are decreasing, it's called respiratory alkalosis. Okay, so if I see it again to make it more simpler, the metabolic acidosis or metabolic alkalosis. Okay, so in metabolic acidosis, the bicarbonate level should decrease, that is, they should fall below 22. And in alkalosis, the bicarbonate level should rise, that is, they should rise above 26. In the respiratory acidosis, the PCO2 levels should rise and that should be above what? What are the normal values? Just go back to the slides and see. And if the PCO2 levels are decreasing, it is alkalosis. Okay, so this is the basic of acid-base analysis to diagnose the primary defect. Okay, so let's see one example. The pH is around 7.2. The bicarbonate is around, say, 16. The PCO2 level is around 48. Now, if we see from the previous lectures, the normal PCO2 levels is around 35 to 45. Okay, and in C, this is around normal. From the first thing, the pH is decreasing, so it is acidosis. Now we have to find whether it's a metabolic component or a respiratory component. So here, if we see the normal value of bicarbonate is 22 to 26, the PCO2 is around normal level. There is a slight increase, okay, but the major component is the bicarbonate in this scenario, which is decreasing. So it is more of a metabolic acidosis. Okay. Now again, if we see another example, if the pH is around 7.54 and the bicarbonate is around, say, 20 and the PCO2 is around 26. So again, the pH is increasing, So it is alkalosis. The primary defect here is the decrease in the PCO2 levels that is componenting to the alkalotic part. So it is the respiratory alkalosis. Okay. So coming further to the points, what is the compensation? So the first point was to see the pH. The second point was to see the primary defect. The third point is compensation. Now, if we Google all these things, or if we see various books, there are n number of formulas for compensation. Okay, if you see any book like Paul Merino or any other Google, there are n number of formulas for compensation. But I'll tell you one basic point that the rule of there are around four rules of compensation. The first response for the compensation is that the organ system should be functioning properly, should be functioning properly for the compensation to happen. What I mean by the organ system, there are two basic organs for compensation, that is kidney and second is the lungs. The kidney corresponds to the metabolic compensation or the metabolic component. The lung corresponds to the respiratory component or the respiratory compensation. Okay, so both of these should function normally. Okay, the acute compensation, coming to the second point, the acute compensation by kidneys occurs faster. That is, it takes 6 to 24 hours, while the chronic compensation by kidneys takes around days, that is 1 to 4 days. On the contrary, the respiratory is much more faster than your metabolic compensation. So, any compensation occurring through the lungs is much more faster than kidneys. Okay, so first was the organ system should function properly. The second is the compensation hours. Coming again now to the third point of compensation. In clinical practice, there is no complete compensation. You have to remember that no matter how much body tries, there are limits for the human physiology to happen, and there is no complete compensation. We can have around 50 to 75% return to the normal physiology. Okay, and the fourth and the most important point, that overcompensation never happens. Never happens. Okay, so these are the four basic points of compensation. Now I'll tell you one very important gold point, that the compensation happens in the reverse manner. What I mean by the compensation happens in return manner, in or reverse manner, sorry. So if a patient is having the primary defect as metabolic acidosis, the compensation for that, for easy remembering, should be opposite of all both the two things. So the opposite of metabolic is respiratory, and the opposite of acidosis is alkalosis. So if we see a primary defect of metabolic acidosis, and if we are saying that the compensation is there, it should be with respiratory alkalosis. And coming back uh, for the metabolic acidosis, the compensation here will be respiratory alkalosis. For metabolic alkalosis, the compensation will be respiratory acidosis. For respiratory acidosis, the compensation here will be metabolic alkalosis, and for respiratory alkalosis, the compensation will be metabolic acidosis. Again, we have to remember that there are mixed disorders also, which we'll deal in a later class. Okay. Now, if we see for the rules of compensation, as I told you, there are four rules. There are the compensation changes also. And if we see the various books or the Google, there are around n number of formulas for the compensation points. What I follow is a basic formula which is easy to remember also. So for the metabolic acidosis, the primary change here is the decrease in the bicarbonate levels. Okay, so the compensation here will be respiratory alkalosis, and for the respiratory alkalosis to happen, the PCO2 levels should decrease. Okay, so for every change, I'll highlight it with a different pen. For every 1 milliequivalent decrease in bicarbonate, the PCO2 levels should decrease by 1 to 1.3. This is the formula which you can apply in daily basis. So if we see that, okay, there's a decrease of 1 milliequivalents of bicarbonate, the PCO2 again should fall by 1 to 1.3. Coming to the second point, that is the metabolic alkalosis. Here the primary defect is the increase in the bicarbonate levels. Okay, so for that the compensation will be respiratory acidosis. So the PCO2 level should increase for the respiratory acidosis to happen. Okay, again for 1 milliequivalent increase in the bicarbonate level, the PCO2 levels should increase by 0.5 to 0.7. This is for the metabolic alkalosis. For the respiratory part, we have again seen that there are 2 points. One is the acute and the chronic part. So for the respiratory acidosis, the point here is the increase in the PCO2 levels. The compensation will be metabolic, that will be alkalosis. So there should be an increase in the bicarbonate levels. I hope I'm clear till now. Okay. So for the acute respiratory acidosis, for every 10 millimeter increase in PCO2 levels, we have to see the expected change in the bicarbonate. And again, the bicarbonate levels should increase, okay, for the alkalotic thing to happen, and it should increase by 1 milliequivalent of bicarbonate in an acute event. For the chronic thing, for every 10 millimeter change in PCO2 levels, the expected increase in the bicarbonates is around 3.5 milliequivalents. Okay, this is a little different because there we have acute as well as the chronic part. So for every 10 millimeter increase in the acute part, the bicarbonate should increase by 1, and in the chronic part, it should increase by 3.5. Now coming to the last part of this lecture, that is the respiratory alkalosis. The primary defect here is the decrease in the PCO2 levels. The compensation here will be metabolic acidosis. So for that metabolic acidosis to happen, the bicarbonate again should fall. Okay, and as I told you that there are two events, one is the acute and one is the chronic. So for acute respiratory alkalosis, for every 10 millimeters of mercury decrease in the PCO2 levels, the bicarbonate should fall by 2 milliequivalents in an acute event, and in a chronic event it should fall by 5 milliequivalents. Okay, so guys, this is a very easy formula to remember. Okay, here the change is 1 for 1 for easy remembering. In the metabolic acidosis, for metabolic alkalosis, 1 to 0.5. Okay, 1 1 1.5, easy. For the acute event, for every 10 change it's 1. For the chronic part in the acidosis thing, 10 to 3.5. Okay, so you can again remember as 1, 3. For the alkalosis, it's 2 and 5. Okay, so metabolic 1, in metabolic acidosis 1, 1, metabolic alkalosis 1.5, for respiratory acidosis 10 to 1 in acute part. In the chronic part, it is 1, 10 to 3, and in respiratory alkalosis, for every change in 10, it's 2 and 5 for acute and chronic respectively. Again, we have to remember one very important point, that if it's the metabolic acidosis, we don't have to stop there. We have to see the anion gap, the corrected anion gap, the delta gap, the delta ratio. All these topics will be dealt in another lecture because of the shortage of time here. Okay. So if an examiner gives you an ABG in exam perspective, I hope an you undergraduate level can easily diagnose an ABG. But before answering the ABG, remember to cross question the examiner whether the what are the FiO2 levels, what is the ventilation or the ventilatory settings of the patient given to you. Okay, and remember whether it's an ABG or a VBG. Okay, so you have to remember all these before answering your question, whether the patient is hypoxic, whether it shows hypoxemia, or the whether patient is showing hypercapnia, and what is the basic defect. Okay, so I hope I made it simpler for you to diagnose an ABG, and we'll see you in another lecture, and keep subscribing to our channel, that is AACCM. Thank you.